Hello, welcome back to my channel. Today we are going to talk about fissure in ano, and we will talk exactly what's written in Bailey and Love Short Practice of Surgery 28th edition. I repeat, 28th edition. So, what is fissure in ano? Fissure in ano is defined as a longitudinal ulcer in anoderm of distant anal canal below dentate line. Okay. So what is a dentate line? Let me small review. Okay, this is an anal canal. Anal canal is usually 4 centimeter in length, and it usually have some demarcation such as this white Hilton line. Then we have this pectinate line. Pectinate is also called dentate line, and above this dentate line usually hemorrhoids are happening. And at this dentate line there's a thing called anal hypertrophied papilla. They usually occur in this line. Okay, so uh, let's go back to anal fissure. It's basically a longitudinal ulcer in anoderm of distant anal canal below dentate line, which means this part. Okay, below dentate line. Understand? Let me make a small diagram for you. Like, it will be happening in this part. Okay, this part. So let's go back to the topic. Okay, so it's a longitudinal ulcer, understand, and it's usually happening in young age but can occur in any age, understand. And it's usually the most common locations of fissure in ano is basically at 6 and 12 o'clock. 6 o'clock is most common in males and 12 o'clock in females, especially after vaginal delivery. When you are going to examine a patient with anal fissure, you will see his anal tone is increased on DRE, and basically there is a whole vicious circle after the initial tear. So let's go back to the anatomy, and I will show you a small thing which you should know. Uh, there is a internal sphincter, okay, and at this internal sphincter what's actually happening is the blood vessels actually pass through this, and due to increased anal tone the ischemia develops, and when this ischemia is developed the healing is compromised. And so if a fissure develops initially, I especially wrote the word initially. Okay, after initial tear what is going to happen is that a vicious circle, a vicious cycle is gonna start. Tear is happening, which will increase in, anal tone, and it will further increase ischemia, which will further increase the tearing process. And the patient is also gonna avoid defecation because it's a very painful process during the anal fissure, and usually patient uh, describe it as a sharp glass passing through, or a knife cutting through. And because of that pain patient is going to avoid defecation as much as possible, which is further going to increase the hardness of stool, and which will also lead to a further tearing, and this is a vicious cycle which is going to take place. And after that usually patient describe it as a glass passing through or knife cutting. These are the words written in Bailey, so you can use it in exam, or maybe the MCQs. Fresh blood on wipes, it's usually after the defecation, understand, and usually bright red colored uh, blood. And if a patient is having a chronic fissure, you will also find a sentinel tag. Okay, a sentinel tag is usually present in chronic fissures because of continuous healing and continuous tearing process. It will lead to fibrosis, and there will be huge you can say side tags which are called sentinel tags. It's mostly present in chronic fissures. And if the location of this fissure is at an unusual place, you should rule out secondary causes or different pathologies. I do categorize into 4 categories. Crohn disease, tuberculosis, STDs, and squamous cell carcinoma. Sometimes Kaposi sarcoma can also lead to this. So if the fissure is at unusual place, you should rule out these pathologies first. Okay. And a patient can also complain of itching because of mucus discharge. It is happening in fissure do have some mucus discharge, and sometimes you will also found a pussy discharge. It is usually present at intersphincteric groove. So what is intersphincteric groove? Consider this is the internal sphincter and this is the external sphincter. The space between them is called intersphincteric groove. So sometimes fissure which is actually happening here. So what is gonna happen is that it can lead to a small pocket formation, and this will discharge pus. Okay, so keep this in mind. And let's talk about the treatment. According to Bailey, the treatment should be conservative first, and it will cure almost all cases of acute anal fissure and majority of chronic fissure. These are exactly words written in Bailey. And you should emphasize on normalization of bowel habits. How can we do that? We can say say to the patient that eat at normal intervals. He should have dinner. He should have uh, uh, breakfast and everything at a regular interval, along with adequate addition of fiber in the diet. You can also prescribe stool bulkers and stool softeners, and a patient should take adequate water intake. Understand? If these simpler methods fail to resolve the problem, then you can use what's described by the Bailey as chemical sphincterotomy. What it essentially does is basically relaxes the sphincter. When the sphincter is relaxed, let me explain it to you. If the sphincter is relaxed and the blood vessels passing through them are also relaxed, so blood flow is increased. When the blood flow is increased, it will help resolve the ischemia, which will lead to uh, healing of the fissure. So how many things we can use is chemical for chemical sphincterotomy is GTN 2%. It is present in is available in Pakistan, and it is come in the formation of 2% GTN. It releases exactly, let me explain to you the word. What it does is basically it releases nitric oxide, which will help release the smooth muscles of sphincter as well as blood vessels. And essentially there is a problem with the GTN is that GTN cause headaches, so you need to tell the patient that he should apply, if this is the anal canal, he should apply GTN only at this place. He should not apply GTN at this place. And there is a significant association of headaches with GTN, so the compliance is very low. On the other hand, you can prescribe two other things, which is diltiazem 2%, which is essentially a calcium channel blocker. You can give it BD twice a day, and GTN can be given 2 to 3 times a day, but diltiazem is prescribed twice a day. And what it does, it's essentially doing the same thing, smooth muscle relaxation, which will lead to the healing of the fissure. You can also use botulinum toxin, 10 to 100 units. It can be given a single or multiple doses. What it does is actually temporarily block the acetylcholine release from the neuromuscular junctions. There is a 10% association of incontinence with this, and we usually do not perform this in routine our practice in Pakistan. Operative measures. Well, the first, there is an anal sphincter dilation. What it does is actually, if this is the anal canal, you will use 4 fingers to dilate it abruptly, but it's not recommended nowadays because it can lead to uh, incontinence. What's used nowadays is called lateral sphincterotomy. What it does is, there are two techniques. There's an open method and there's a closed method. Almost all the steps are same. you are going to perform in two positions. First is lithotomy position, and second is prone jackknife position. And it in open, you are going you can do a procedure in local, regional, or general anesthesia. Same for the closed method. You can use a bivalve speculum to retract the intersphincteric groove. This is special instrument what we are going to use is bimanual speculum sims, TK, and it can retract the anus, and you can perform the procedure. Then you are going to give a longitudinal incision at intersphincteric groove. At usually it is given at if this is the anal canal, it's usually given at 3 and 9 o'clock positions, depending upon surgeon's dominant hand. And there is a rule which you should know. If this is the anal canal, you should know that if this is the dentate line, and usually sphincter present over there. So if the fissure is at this level, you can do a sphincterotomy, which is good. Usually sphincter is like this thick now. So if the apex of the fissure is at this level, you should reach your sphincterotomy fibers. You should cut your fibers up till this point. If you are not going to cut your fibers up till this point, the healing can be uh, impaired. Okay, so results are not that good. So you should perform up till the apex of the fissure. So in open method, sorry, I have actually miswritten this as open. This is actually closed method. In closed method, we use blade, or what you can say, we can use blade or knife to cut the fibers. And you can watch many YouTube videos. They're available on YouTube, so you can understand by that from them. And in usually open method, the fibers are taken out from the incision site and then they are dissected, and all the steps are same. After the cutting, fiber pressure should be applied to prevent the hematoma, and the incision should be closed with the absorbable suture. And if there are skin tags present, for example, if a skin tag is present around, this is a chronic anal fissure and the skin tag is present, so you should perform lateral sphincterotomy over here, and you should remove the exercise. It will provide the psychological comfort to the patient. Along with that, patient usually do say, if you do not remove it, they will say you have not performed the surgery. So it's a common practice Pakistan that we do remove papillae or tags, sentinel tags. How much sphincter should be divided according to Bailey? It's up to the debate and based on the patient factors such as postpartum and everything. Healing is almost 85% in most cases, and complications, the in early complications can include hemorrhage, hematoma, bruising, perianal abscess, and fistula formation. Fistula usually form if you are disrupting the mucosa. If you are performing a closed method, for example, these are the fibers and you are inserting a knife into it and rotating it and cutting these fibers. If you cut through the mucosa, you can actually induce a fistula. So do not cut the mucosa. Late incontinence late complications include incontinence, flat incontinence. 9% of the case is soiling is basically a small you can say this is a not solid stool incontinence, but it's a small you can say stains of stools, and solid incontinence in less than 1% of the cases. uh, then there is although another technique called fistulectomy. In this, if for example this is the anal canal and this is a fissure, so let me explain to you. This is a fissure, this are, for example, this is the base of a fissure. You are going to curate this, and you are going to excise these boundaries, and if there is a tag present, you are also going to excise this tag. Understand? And it is usually combined with the advancement of flap anaplasty. And in anal advancement flap, it's usually performed in women with postpartum, or the women who have a risk of incontinence, of decreased anal tone, patients with degrees and tones, and you're going to perform an inverted house flap. For example, this is a house, this is there's a very good picture in Bailey, you can watch that, you can see that. uh, and you're going to place that flap with the absorbable sutures, and the blood supply is usually taken with the flap. And if a minor breakdown happens from any one point, it does not usually predict a failure of the flap. Then there is another thing which is very important to understand with the context of anal fissure, is that sometimes with anal fissure, patient do present with hypertrophied anal papillae. What are anal papillae? Anal papillae are usually present in 60% of the cases, and they should be considered normal, and they are present at dentate line. They are actually the remnant of ectoderm membrane. Understand? Sometimes in fissure they can lead to pruritus. If hemorrhage happens in one of the papillae, it can lead to sudden rectal pain, and usually red edematous. And sometimes if for example this is a papillae, this is an anal canal, and this is a dentate line, there is a papillae over here. Sometimes there is a small glands which are secreting mucus, and they can get infected, and they will lead to cryptitis. Understand? And cryptitis at the base of stabilizer. And by this we have concluded our topic of anal fissure in ano, according to the Bailey 28th edition. Thanks for the watching. Allah Hafiz.